Hello, everyone, and welcome to Speaking of Wounds, a podcast by Today's Wound Clinic. Today I'm here with Rosemary Hill and Martha Kelso. Rosemary is a wound care ostomy nurse at Lions Gate Hospital in Vancouver, Canada. Martha Kelso is CEO of Wound Care Plus, where she leads a team of advanced wound care specialists providing wound care across 14 states.
Hi there. Thanks, Brian. I got to tell you, I'm really excited today to talk to Martha, as we're both really passionate about the decisions that happen when it comes to wound care. And we're big fans of technology during patient visits and trying to engage our patients with their wound healing trajectory. Martha, welcome. And I'm wondering if you could just tell me a little bit more about some of the wound care you do and and what your team provides.
I'm excited to be here with you, Rosemary. You're one of the early adopters of this technology, and so I'm very excited to be in the same podcast as you. It's very humbling. I appreciate the questions. My company is a company of doctors, nurse practitioners that perform differential diagnostics for wounds at the bedside. So we like to refer to ourselves as advanced wound consultants or advanced wound specialists. We perform everything from debridements to biopsies, skin grafting, multi-gradient compression wraps, total contact casting, pretty much everything except hyperbarics. We like to say we're the wound center coming to them. I would say the majority of our clientele is in the long-term care space, but we do go to acute care hospitals, intermediate rehab facilities, what they refer to as IRFs. So we're in 7 different MACs and 14 different place of service codes. Do you mind telling me about your background and history?
Sure. I guess I've actually been nursing for probably almost close to 35 years, but most in the last 15, it's been around the area of wound and ostomy and continence. However, my day-to-day work life definitely is probably 60% seeing patients with complex wounds. I see both patients in the out clinic center. From 8 to 4, we have an infectious disease specialist who sees patients related to, say, chronic wounds, diabetic foot ulcers. And so we put our heads together to say, how is our team going to help this person? And then, of course, there's the inpatients. Within the hospital setting, where I would say certainly we're looking at various pressure injuries, chronic venous leg ulcers, and the like. I kind of want to, one thing that's really, maybe even personally is touched close to home here during the pandemic has really been for our people in the long-term care setting, which you mentioned, and I'm kind of intrigued. Our people have really, I guess there's no other word for it, but they've really suffered in terms of not getting contact, and they've missed the contact with their family. And so I wonder, when you've been going into the long-term care settings, have you during the pandemic noticed a change, and what's been happening in that regard? And do you see the loneliness factor and the impact of some of the isolation they've been experiencing?
We do. I mean, the isolation impact has been enormous in the long-term care, assisted living, group home sector. And the other challenge that we experience when you're mobile is kind of the presence of mind that you could be Typhoid Mary if you're not careful. And so we had to put protections in place early on. So if somebody was symptomatic or in isolation for COVID or COVID-related precautions, we would have to go to the nurse's station and do telehealth instead of going in the room.
Right.
And so that becomes, well, what if they need debrided? Well, sharp debridement may not be an option. We may have to utilize other forms of debridement where sharp debridement might have been our go-to. And then the other, this isn't funny, but it's true. And the worst part is it happened more than once to me. So you apparently I didn't learn the first time, but wearing an N95 mask in the middle of clinic when odor is one of your clinical signs and symptoms of infection that you're used to assessing, suddenly you can't smell through the mask. And what happened to me was, not realizing I couldn't smell through the mask, I kept putting the dressing closer and closer to my face and contaminated my N95 mask with wound drainage. And again, not once, not twice, it probably happened to me 3 times because I'm so used to trying this.
Sure, it's instinctive. We bring it to the nose. That's right.
Yeah. So it's like, and now we need to stop rounds so I can go change out my PPE mask. But it was kind of daunting. Well, how do we assess for clinical signs and symptoms of infection when one of my key symptoms I can't assess for?
And so is this something, now you have a Moleculite in your practice. That's part of one of your assessment tools when it comes to looking at wounds in patients. As that, how has that helped you during the pandemic?
It's helped immensely. But the interesting thing is we didn't get access to MolecuLight until probably 3/4 of the way through the pandemic because it wasn't reimbursed in the long-term care space. And so I had to reach out to Medicare and payers to say, please help us cover this. And then they granted it to us. We were able to implement it in November of 2020. So, that 6 months leading up to it, when you have elderly patients that are immunocompromised, so they don't always have the normal clinical signs and symptoms of wound infection that a 40 or 50-year-old may have.
Right.
And then you're taking away my odor ability to interpret odor on top of it. So by adding MolecuLight, it was almost that hallelujah moment, aha moment.
Yeah.
And worse, I went out in the field the very first few times that we were implementing MolecuLight. I wanted to see it for myself. I wanted to see the feedback.
Sure.
And I would say between the first few days, we went probably 95% of the time, it was changing what we would have done. We found all kinds of things that normally you wouldn't have thought, gosh, this wound is infected. Let me get a culture, or let me try to sharp to breed and then do a culture. And so it was very eye-opening how much we're actually missing based on the old clinical signs and symptoms.
Yeah.
What are your?
Well, I have, in terms of the MolecuLight in the acute care setting, it definitely has been an eye opener for sure. I want to go back though a little bit to the COVID. I have found our patients are very wary as they come into our place, and they're scared they're going to get something. And so, and all they do is see my eyes. They can't see anything more about me. And so we talk, and then I say, I want to bring a little more information about your wound to both of us. And so I like to take the time to take the MolecuLight and tell them that, what I'm going to do is, and I just kind of give a brief information about what really is the MolecuLight. And I explain that I'm going to shine a violet light on their wound. And I'm hoping that's going to tell me a little bit about how much bacteria is there, and even to some degree, the kinds of bacteria. Is it Pseudomonas, or is it lighting up red? And then what I like is I like to show them on the MolecuLight what their wound is looking like. And it's just, so much of who we are as a person and our facial expression, everything like that has been taken away because of our PPE. But I can turn around and show them in MolecuLight in the screen. And for so many patients, sometimes it's their diabetic foot ulcer, their pressure injury, and you really do want to engage them as to what we're going to do next. So I'll say, you see that red area? We're going to take some time now, and we're going to use a bit of a cleanser. And find there's more of a collaboration, a partnership with what the next steps are in the wound, because they are actually seeing the same information that I am getting. And of course, I mentioned that it's been helping with the patient engagement because of all the other layers that are barricading the engagement. But it's also something I can show the team. So I love that I can go and turn it to the OT, physio, or the physician to say, hey, just looking at this pressure injury, I'm seeing some issues here. So for me, it tells us so much more, and then tends to guide us as just exactly what you said, where we might debride it, where we might, after cleansing, see still a preponderance of bacteria and maybe culture. So it actually targets our culturing. Those are some of the things that I would say where the MolecuLight has really enhanced our practice for the team, because everybody, even the nurses on the floor, hey, Rosemary, what's that? What's that you've got? Can we look too? You know? It's a very engaging tool. And I just love the ability to engage people. And I know, Martha, you're passionate around wound care, and as I am too, but it's wonderful when we can entice others to have a similar interest and passion when it comes to wounds, as opposed to, ooh, it's a wound, you know?
Yeah. And they light up. They're so excited to see new technology that doesn't hurt. So
yeah.
Let me ask you this. You've been one of the early adopters. I mean, you've been using this for years. So for your colleagues, the listeners, people that are not familiar with MolecuLight, how do you describe it to them and help bring them up to speed?
So I'll mention that, look, right at the point of care, I'm going to just turn this device on. I'm going to shine a light. And literally within seconds, I have a picture of what's going on at the wound bed. There's nothing, I'm not using any other particular, I'm not using anything else but shining a light on the wound. And for some of my colleagues who want to embrace the technology and say, Rosemary, can I do that? And I'll say, you know what, I absolutely. But what we'll do is we'll set them up for a learning module, and they'll step by step, we'll take them through how to use the device, the distance, how close you want to be to the wound, and just a few features so that there's an element of discernment when you begin to use the MolecuLight. So I think that's probably an important thing to say. Yeah, there's a little bit of education. So we all use it in the same way at the same distance. I think that's important. I would say, I'll tell you right off the bat, it has definitely expedited care. So for me, I've come across, it's usually, I'll get a call, Rosemary, can you pop upstairs and see this lady? I'm seeing something on her coccyx. Would you mind having a look? I'll usually, always for pressure injuries, I love to bring the MolecuLight. And it's like, whoa, it lights up. So right away, I can start with some kind of antimicrobial intervention, whether it be dressings, and also engage the physician that this is not just a superficial pressure injury. We have something else happening here as well. And so in some instances, with wounds that didn't have redness, we've immediately, even on interesting cases, we've had a CT scan. It's expedited care to having actually an abscess drained. So it's really kind of mobilized care efficiently. Whereas I think, with cultures, you have to wait 48 hours, 72, there's a bit of a guessing game. So that point of care of shining a light and sharing it with the team, absolutely, Martha. I bet you, I'm sure in your long-term care setting places that you've been visiting, it's the immediacy of which you're getting information, I would say.
It's user-friendly, and then, not painful, non-invasive. You don't have to touch the patient or the wound with it. And, it's literally seconds and the real-time feedback. And we have found, like you said, we found hidden abscesses after debridement. where we thought, man, this wound is clean. It looks brilliant. It's going to go on to heal. You know what? Maybe I should fluoresce or I should point the device at this wound one more time just to make sure I got everything out of the wound that I wanted to get out of the, and there was a hidden pocket of abscess. And in the elderly, that is the difference between life and death, right? Because that hidden abscess, it's just waiting for sepsis. It's waiting, to deteriorate. And in a COVID world, they don't want to have to go out to the ER or, be admitted to the hospital around more sick people. And I will say too, that I do a lot of expert witness cases around the country, and a lot of them are surrounding wounds and sepsis or wounds and infection. And so by having real-time feedback, we know, we're not guessing, we know hands down when we walk out of that room whether or not that wound is infected instead of guessing.
Right. Martha, early on, you mentioned about the elderly and sometimes the limitations around how their bodies respond when there is infection. And it's not like a 40-year-old. And I'm glad you mentioned that, because I find the same thing a little bit with diabetic foot ulcers. With a diabetic foot ulcer, you don't sometimes get the same degree of erythema that you're expecting with infection, right? Some of their responses, as we know with diabetics, it's different. And so that's where, particularly in our medical day center, that's with our ID doctor, where we bring the light and we can shine it on the diabetic foot ulcers. And we're just getting more information than we normally would have. And so, I see the similarity with the elderly as well. So it's proved useful in many ways. And you make some good points. Yes, you just carry it around your pocket. Yes, it's an easy wipe down. It's a wipe down as you go from patient to patient as necessary. These are some of the things that in this day and age, when we're kind of burdened with all of our gear, the changing and all of that. And in the COVID rooms, there's a sleeve that you can use to protect the device. So those things really help, because we don't need to add to our workload at the moment.
So what do you think about the future of this device? Do you think it's going to become a standard of care where if groups aren't using it and wounds are deteriorating under their care, they may be penalized, or maybe lawsuits will adopt it as a standard of care? What are your thoughts?
Wow. And it's so interesting, me being in Canada, you being in the States, sometimes the litigation aspect of things. I think I see it as a complementary, but a very necessary tool. I think we have a responsibility to our patients that in this day of being careful with antibiotics and antimicrobial stewardship, we just don't want to just go, hey, just in case, let's put them on antibiotics. No, we want to have a little bit more objective clinical signs and symptoms. So I actually think, I do think we need to be adopting this in our practices. Again, a personal sharing. My dad had C. diff only after a couple of doses of Keflex, had to have a round of Vanco, and then he had a round of Flagyl. And again, it reoccurred. And finally, he had a special medication, which was here in Canada, close to $1,000, which finally eradicated his C. diff. So I am a person, because of that personal experience with my dad, I want us to be really careful when we decide, yes, we need to think that this person, particularly with the elderly, we need to be careful that we just don't, just to be on the safe side, prescribe antibiotics. And maybe topical administration of dressings would be sufficient. And so we need that Moleculite. And I probably speak passionately about that because of my dad. but I don't know what your climate is like in terms of antibiotic therapy. And also there's cost associated to some of our antimicrobial dressings too. So we want to be cost effective. And we also have people who are very worried about silver resistance. Let's not be over prescribing or overusing silver products, because they too may cause an issue. And so I think we need to be judicious in our wound care choices, both dressing and antibiotic. We need to be, I feel like I'm old fashioned. I want to be a real ambassador for a real standard of care for our patients with complex wounds. And I definitely need the MolecuLight in my practice to help me with that.
Mm-hmm. In the States, there's a regulation that, and it's about antibiotic stewardship in the long-term care sector. But we take it one step further like you do, and it's not just about antibiotic stewardship, it's about antimicrobial stewardship. And I literally just finished authoring a paper on it within the last week, to where when we're exposing elderly people or wounded people to some of these things, they have wounds because they're sick. The healthy patients don't get wounds. And so they have wounds because they're sick, or there's an underlying metabolic process that's failing, or causing this impetus for, or polypharmacy. The side effects of medications can cause wounds or delay wound healing. And so I feel like when you have a tool that's so powerful that at 10 to the fourth power, whether or not bacteria is proliferating in that wound, you're not guessing, know whether or not it's there, and you're not adopting it, and there's reimbursement for it, meaning you're not out of pocket. There's groups that are, the payers are paying to help support this technology to eliminate as much as possible the negative effects of antibiotics or antimicrobial effects, whether that's, silver killing cells, or, we're leaving silver in the wound bed too long, or, those kind of things. To me, it's just a no-brainer. And as the CEO for my company, I thought the second I was introduced to the technology, I thought, my gosh, can you imagine the ripple effect of rolling this out, throughout the entire company, and the benefits that it has for our clients. I think about Cipro, and I grew up in the long-term care sector. I've been in healthcare 30 years, and I've seen, I ran an Alzheimer's dementia facility. And so they would get a UTI, and we would often, Cipro was often the sensitive medicine. We'd put them on Cipro, and they would be so confused. And the side effect of Cipro is it can be confusion in the elderly, let alone the demented elderly. And so the side effects of antibiotics are just so devastating at times to our elderly population. So
and so in that way, I feel that this is the most responsible way in this day and age that we're living in, to have this device. And I can see in your world, it definitely is impacting your practice, but it's impacting your patients foremost. And so I think that's key. And I think, I maybe was one of more of the earlier adopters. And I hope that others get a chance to listen to us today to hear about how it's impacted our patients. And it's changed our wound care practices. It's changed our wound care assessment, and it's guided us in both debridement, culturing, I'm just sort of summarizing here a few things, Martha, before we close. Do you have any last minute comments before I take a moment to end our opportunity of speaking of wounds on the podcast?
I'm thankful that you were an early adopter, pioneering and getting that path so groups like mine can use this technology. So I just want to thank you for your diligence and jumping in and championing this product.
Well, thank you. And on behalf of all those people in long-term care places, I am so glad that there's a Martha out there. You have joy in your voice, and they need to have some joy and expertise coming to their doorstep. So thank you. It's been great to have this chat with you, Martha. I hope one day that we connect again. And I just want to say thank you, Brian, and I appreciated having the opportunity of speaking. Both Martha and I have appreciated the opportunity of speaking of wounds today for the podcast. Thank you.
Thank you, Ro. Thank you.